Hi, I'm Ken Cutbush. I'm an orthopedic shoulder surgeon working in Brisbane. I'd like to share with you a very interesting case of a patient of mine. This is a patient who's had a rotator cuff repair. He's 73 years old, and I'm going to share his MRI scans with you. We've got pre and post-op MRI scans to look at, one at 6 weeks and one at 12 weeks post-op. And it's very interesting to have a look at them and see what happens with the MRI scans with the rotator cuff. So we start with this one. This is pre-op here. And we can see the humeral head coming up here. There's the ball, the socket, the shoulder blade is there. That's acromion, that's your AC joint, that's the collarbone. You can see the outline of the skin and the deltoid. And this is the rotator cuff on the top of the shoulder with the supraspinatus. There are 4 components to the rotator cuff in the shoulder, and this is the supraspinatus here. You can see here, this is the tendon just here, just that little black or dark grey tendon there, and it ends here level with the joint line or level with the glenoid. This is the muscle back here. And you can see the humeral head is almost touching the acromion. It's what we've called superiorly migrated. And that's a very poor prognostic sign when it comes to predicting the outcome of a rotator cuff repair. And the tendon used to go from this ledge of bone here. The tendon normally stretches across the cartilage. You can see the black line is bone, and there's a little grey layer there which is cartilage, and the tendon normally comes right across that between the acromion and the humeral head to this ledge of bone over here, the tuberosity, and attaches there. And it's torn off here and retracted back level to the glenoid, and that's 4 to 5 centimeters of retraction there, which is quite a lot. If I take you through this scan, you can see the teres minor, the rotator cuff at the back of the shoulder, right down the back, is intact, but then infraspinatus is completely off. You can see this is the infraspinatus tendon here. This is humeral head coming up here. The tendon should be stretching across here. As we come across, you can see here, this is the supraspinatus now. And the tendon is curled up there, bunched up. It's retracted back and bunched up in the shoulder, and the humeral head's been allowed to go superiorly because of that. And as we come across, so it's torn. This is the bicep tendon here coming over here. The bicep tendon attaches to the socket over here, then comes across the top of the humeral head, and then down this groove down here. You can see the little black line of the bicep tendon, and the subscapularis doesn't look completely normal at the front of the shoulder either. So this is a very, very large rotator cuff tear with a lot of poor prognostic signs. We're going to now look at this view here. And what we're looking at this view for, this is the Y view of the scapula. And we look back here because these muscles here are the muscles that go to those tendons. And we can see subscapularis looks quite good. This is teres minor. This is infraspinatus and supraspinatus. What we see with the supraspinatus and the infraspinatus is there's a lot of white in there. On this particular scan, white is fat. You can see the subcutaneous fat there. And so we've got fatty atrophy and fatty infiltration of those rotator cuff muscles. And that indicates that this tear has been there for a while, usually a couple of years. And that in itself is another poor prognostic sign. So we're a bit worried about this rotator cuff, but we have discussed it in detail, and we've elected to go ahead with the rotator cuff repair. And the rotator cuff repair has been successful. That's what I'd like to share with you. So we see here, this is at 6 weeks post-op. And what we see now, the humeral head is down. It's right down where we want to see it. The humeral head is down, almost to the level of the bottom of the joint there. And we've got a much bigger gap between the acromion here and the humeral head. We've taken a little bit of bone off the acromion to do an acromioplasty to give it more room. We want to give when you lift your shoulder up to the side, this area of rotator cuff has to swing underneath this ledge of bone called the acromion, and that's when you catch. So we want to make sure you've got more of a gap there so there's more room for the tendon to roll underneath the acromion, so it's not much less likely to catch. And we can see really good quality tendon coming across and joining onto the bone over here. You see the bone is a bit bright. It's got a bit of whiteness to it. That is bone edema, and that's due to the anchors being placed into the bone and bone bruising. And that shows us that this is a MRI scan taken shortly after the operation. This is the 6-week MRI scan. But the rotator cuff is intact. I was just a little bit worried about the rotator cuff at this stage, and I've asked the patient to stay to go very carefully with the shoulder after that 6 week, between 6 and 12 weeks. And I've asked him to wear the sling when he's out of the house, so we can make sure that we keep this rotator cuff intact. You can see the bicep tenodesis here. So the bicep is coming up here, and it's coming up to this anchor down here, and that we can see that that's intact. And then we go to the 12-week scan, and the 12-week scan is looking even better. You can see here now the tendon, a lot of the brightness out of the humeral head is gone, so that's starting to recover, starting to heal. And we see a really nicely intact rotator cuff tendon coming across and joining onto this ledge of bone here. And the the tendon itself is starting to darken up. Some of the fluid is going out of that tendon, which indicating that we're going down that healing process that we want to see. And you see here, the bicep tendon has been tenodised. You can see the stump of the bicep here. So tenodesis means we connect the bicep tendon here, and then we take it from inside the joint, excise it out of the inside from the glenohumeral joint. Once we've got it tenodised here, it has to be taken out of the joint, because otherwise it will crumple up inside the joint when you lift your arm up and cause problems. And we've done that, and the tendon here looks really good. And now we can see teres minor, we can see the infraspinatus is intact, we can see infraspinatus, and now we see the supraspinatus intact as well. And that's a really nice looking rotator cuff repair at 3 months. It's very unusual to see a tear after 3 months. In my experience, the tears occur between 6 and 12 weeks. When patients come out of the sling, they start moving the shoulder too much, and that's when the rotator cuff tears actually occur. They don't, once we see an intact scan at 3 months, we can relax, because it's extremely rare for me to see a rotator cuff tear happen after 3 months. So at 3 months, once we've got the rotator cuff intact and healed on, that's when we can start moving things. And this issue of the rotator cuff re-tear is a significant issue. To fill you in, there have been multiple overseas studies performed of randomized controlled trials and large series of rotator cuff repair patients, and they consistently show re-tear rates in the order of 40%. One of the most well-known trials was the UCUF trial, UKUFF, that was performed in the UK. It was undertaken through multiple sites and multiple surgeons with both arthroscopic and open rotator cuff repairs, and the overall re-tear rate for a full thickness tear of the rotator cuff was 40%, which is huge. It's almost, you're coming in for an operation, you're almost flipping a coin as to whether it would be successful or not. Now, the re-tears appear to be related to too much movement, and what I've found is if we slow everything down for the first 3 months, it's extremely rare to see a re-tear. And that's been a big change in my practice and a big benefit for the patients, because we can give you back your shoulder at 12 months down the track if we can keep it intact for the first 3 months. So it's that first 3 months that's critical there. And you can see here an example of a rotator cuff repair on a 73-year-old who really wants his life back, wants to get back to the gym and get back to doing things. And he had so many things against it. The tear was retracted back to the level of the glenoid. It was a 3-tendon tear. There was fatty atrophy and fatty infiltration. And the worst prognostic sign is that superior migration. There are some surgeons who would say that that was an absolute contraindication to a rotator cuff repair. It's not. We just have to be very careful with that first 3 months. So just a really interesting case to share with you, and to go through the difficulties of getting a good result from a rotator cuff repair. I hope that helps you understand the rotator cuff repair surgery a bit. Hi, I'm Ken Cutbush. I'm an orthopedic shoulder surgeon working in Brisbane. I'd like to share a very interesting patient case with you. This is the case of a 73-year-old man. You can see here, this is MRI scan preoperatively. He's got a very large rotator cuff tear. And you can see this is the humeral head coming up here with the ball, the socket, the shoulder blades here. This is the AC joint, clavicle. That's the acromion that's part of the shoulder blade. And then the skin outline is there. This is the deltoid muscle down the side here. This is the supraspinatus muscle on the top of the shoulder. There's 4 rotator cuff muscles, subscapularis at the front of the shoulder, supraspinatus on the top, infraspinatus around the back, and right down the back is teres minor. So it's only one of 4 rotator cuff muscles. It's the supraspinatus, it's the most commonly injured. You see the tendon coming forward here, it's detension, it's wiggly, and it ends here, at this point here. You can see the acromion, the humeral head, and in between the two is a little bit of fluid, which is the white, and the white continues over to here. That tendon there, which ends just here, used to end all the way out over here on this ledge of bone over here. It comes across the cartilage. You can see there's a little black line, which is bone, and there's a little grey layer, which is the cartilage, and it ends here, and then that ledge of bone is where the tendon used to attach to. And the humeral head has migrated superiorly. You can see here, all this white down here, that level there of the humerus of the arm bone used to line up down here, so it's migrated up about 1 centimetre or so, and it's almost contacting the acromion. That in its own is a very poor prognostic sign for a rotator cuff repair, for the success of a rotator cuff repair. The other prognostic sign, the tendon is retracted back to the level of the glenoid, so it's a long way. It is retracted almost 5 centimetres, and so from here right over to here, and that in itself is a very poor prognostic sign. Just going to take you through this MRI scan. So if we go to the back of the shoulder, we can see teres minor here, right down here. Teres minor is a muscular part of the rotator cuff. There's no tendon as such. And then above that, this is infraspinatus here. You can see the infraspinatus is torn off. If we take you through, you can see the end of the infraspinatus there. This infraspinatus tendon should be stretched out and attached onto the bone. Then we shouldn't be seeing this fluid here. The white there is fluid. And as we go through, we see the humeral head coming up, and the tendon is just bunched up, curled up here, right back level with the level of the socket or the glenoid. As we come through, so infraspinatus right off, supraspinatus is right off, and we come forward. Subscapularis is partially torn as well. You can see the bicep tendon here coming up in the groove. It's just this black line here comes up to the top of the groove, and the top of the groove comes across to the socket over here, to the glenoid, and joins in there. And I've repaired or tenodized the biceps at the same time as when I did the rotator cuff repair. Now he's come back to see me at 6 weeks and 12 weeks post-op, and we have an MRI scan for both of those time periods. It's important for me to check that the repair remains intact. It guides our rehab, and it also confirms that the repair is intact. There's no point doing endless time in a sling or time doing rehab if there's been a complete rotator cuff re-tear. You need to keep in mind, overseas studies have consistently shown re-tear rates in the order of 40% for a full thickness tear. A very large U-cuff trial in the United Kingdom a few years back. This was a multi-center trial, open, arthroscopic, multiple centers, multiple surgeons. Their results were a 40% re-tear rate for a full thickness tear in the rotator cuff. Re-tears are a big thing. It's probably the biggest issue with a rotator cuff repair. If we can keep that rotator cuff intact and it's the first 3 months that's key. They tear in the first 3 months. They typically tear actually in the second 6 weeks. So patients come out of the sling at 6 weeks and they start doing too much movement, and that's when their rotator cuff re-tears. And that's what I've seen consistently following patients with MRI scans at 6 and 12 weeks, and then a lot of them at 6 months and again at 12 months. And that has been consistently borne out in what I've seen following my patients. So we get an MRI scan at 6 weeks, and this is the MRI scan here that I'm going to share with you at 6 weeks post-op. You can see the difference. The humeral head is down. You see that the joint is lining up. The bottom of the humeral head is lining up with the bottom of the socket. That is the way it should line up. And you now see a big rotator cuff tendon coming across the top of the shoulder. I've done an acromioplasty. I've trimmed a little bit of bone off the undersurface of the acromion there to give you more room. I've taken a little bit of the lateral edge of the acromion off as well, a lateral acromioplasty. And you see this very big tendon coming across, and you see the distance between the undersurface of the acromion, that's part of the scapula, on the top of the humeral head there, that is dramatically increased compared to what we had preoperatively. when you only had a few millimeters there. So we've gone from a few millimeters gap, almost no gap, to almost a centimeter of gap there, which is what we want to see. You can see the anchors there. I've used biocomposite anchors here. These biocomposite anchors will be resorbed and replaced by bone. They have a plastic polymer in them, PLLA, and that is then combined with tricalcium phosphate, which bone sees as similar to hydroxyapatite, which is what bone is made of. So bone will grow into it and replace that anchor with bone. So it takes about 2 to 4 years for that to happen. So the multiple anchors, there are a lot of anchors in there, however, they're all going to go away. The bicep tendon has been tenonized. You see the anchor down here, and this tendon looks very good. I'm a little. You can see the white around the anchors there. That is bone bruising associated with the anchors being put into the bone. So you can see that reaction there. You know that this is only a few weeks after the operation because of that. And the tendon here, I was a little concerned that the tendon might be just starting to back off there. You see there's a little gap just there, and so we asked Kerry to be very careful with the. I mentioned his name, so I'll have to go back.
Was that just then, or did you?
Yeah, I said Kerry. Yeah. So I'll just go back. Where could I go back to?
You were too far in really to do it again.
No, we'll just go back. It'll be all right. Where is the anchor? It's almost like that's someone else's. That's his other shoulder too. I'm going to have to start again.
From the top?
What's buzzing? That's me, isn't it?
Put it on Do Not Disturb.